Welcome to this resident teaching session on valvular heart disease. Over the next 15 to 20 minutes, we will build a practical bedside framework for the four major valve lesions: aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. We will follow a consistent pattern. For each lesion, we'll cover the cause, the mechanism, the characteristic murmur, and the management, including the key question of when to intervene. Before diving in, let's anchor the cardiac cycle. Systole is when ventricles contract and blood is ejected. Diastole is the filling phase. S1 marks the start of systole, S2 the start of diastole. Remember that a valve can fail in only two ways: stenosis, which is a failure to open, and regurgitation, a failure to close. These simple mechanics dictate the pathophysiology of every lesion. Where does each murmur live in the cycle? Aortic stenosis and mitral regurgitation are systolic. Aortic regurgitation and mitral stenosis are diastolic. Knowing when the blood crosses the valve tells you the timing. Location and radiation are key exam skills. Remember, all patients take meds for the four listening posts. Radiation patterns, like aortic stenosis to the carotids or mitral regurgitation to the axilla, are powerful diagnostic clues. Aortic stenosis is primarily a disease of aging and calcification. It causes pressure overload, leading to left ventricular hypertrophy. Symptoms like angina, syncope, and heart failure are ominous, starting a survival clock for untreated patients. Physically, look for a harsh, late-peaking murmur at the right upper sternal border. A key sign of severity is, quote, pulsus parvus et tardus, a small, late carotid upstroke. Echo confirms the diagnosis with velocity and valve area. There is no medical therapy to fix a stenotic valve. Once symptoms appear or the ejection fraction declines, valve replacement is required. Options include surgical SAVR or transcatheter TAVR, chosen based on patient risk. Let's apply this to a case. A 74-year-old man with exertional chest pain and near syncope. His exam shows a harsh systolic murmur and a delayed carotid upstroke. What is your diagnosis? This is severe symptomatic aortic stenosis. The clinical picture is classic, and the echo data confirms it. The next step is a clear indication for valve replacement. Moving to aortic regurgitation. Acute cases are surgical emergencies due to sudden volume overload. Chronic cases are often silent for years as the ventricle dilates to compensate, but prognosis worsens once symptoms develop. Listen for an early diastolic decrescendo murmur. Peripheral signs like head bobbing and nail bed pulsations point toward the wide pulse pressure typical of chronic regurgitation. For chronic aortic regurgitation, surgery is timed based on the ventricle's size and function, not just symptoms. We replace the valve before the left ventricle sustains irreversible damage. In our second case, the patient is a 39-year-old with a bicuspid valve. He has a wide pulse pressure and characteristic peripheral signs. How would you approach his management? This is chronic severe aortic regurgitation. The heart ejects a large volume that leaks back, causing a wide pulse pressure and characteristic physical signs. Because his echo shows early signs of ventricular decompensation, he needs valve replacement now, before irreversible dysfunction occurs. Next, let's explore mitral stenosis. The cause is almost always rheumatic heart disease. Think of it as an upstream cascade. The narrowed valve obstructs filling, forcing pressure to back up into the left atrium and pulmonary circulation. The hallmark is a mid-diastolic rumble with an opening snap. Because this is an upstream disease, the left ventricle itself is spared, and symptoms like dyspnea and atrial fibrillation dominate the clinical picture. Here is a classic presentation. A young woman from an endemic region with progressive dyspnea and atrial fibrillation. The physical exam confirms the diagnosis with a loud S1, an opening snap, and a characteristic apical rumble. Management requires rate control for the atrial fibrillation, anticoagulation with warfarin, and mechanical relief of the stenosis. Balloon valvotomy is ideal if the valve morphology is favorable and there is no thrombus. Turning to mitral regurgitation, we must distinguish between primary disease of the valve and secondary functional regurgitation. In primary disease, the valve fails. In secondary, the ventricle dilates and pulls the valve leaflets apart. The murmur is holosystolic and radiates to the axilla. A bedside trick is using hand grip to increase afterload. This makes the regurgitant murmur louder. Primary cases often require surgical repair, while secondary cases focus on treating heart failure. Consider this case. A man 4 days after an inferior myocardial infarction presents with sudden, severe respiratory distress. He is in shock, his lungs are filled with fluid, and he has a new systolic murmur. This is acute severe mitral regurgitation due to papillary muscle rupture. The small, unprepared atrium cannot handle the volume, leading to flash pulmonary edema and cardiogenic shock. This is a surgical emergency requiring immediate intervention. We can organize all 4 lesions into a simple grid based on timing and shape. Systolic murmurs include aortic stenosis and mitral regurgitation, while diastolic murmurs include aortic regurgitation and mitral stenosis. Key takeaways. Stenosis is pressure overload causing hypertrophy. Regurgitation is volume overload causing dilation. Always distinguish between chronic cases and surgical emergencies, like papillary muscle rupture or acute aortic regurgitation. Remember, which way should the blood flow and where does it back up? Use this framework to reason through any valve lesion. Thank you for watching this teaching video.